Louise,
All
can you hear me?
right.
There's a little interference happening. Okay. Can you hear me okay?
Yep.
Okay. Welcome.
Thanks for listening.
You're our second candidate victim on our live stream at PHC.
Great.
And I really, really appreciate you joining us in this new and exciting venue. I've been excited to talk to you for months, but in the last couple weeks, I've had a huge need to connect with you. So I'll quickly introduce myself and say a few things, and then I'm going to ask you some questions. Sure. Okay, so Laurie Francis here. I'm the Executive Director at Partnership Health Center. Really excited to be with you today. Partnership Health Center is a federally qualified health center. You know a lot about us. We see 16,000 people in Missoula and Mineral County. Are here for all. We offer primary medical, dental, behavioral, and pharmacy care. And health centers were started, long ago, and I'll talk a little bit more about that later. But a lot of what we see happening with COVID, and also really since COVID in Missoula and also in the country and internationally, causes me to want to talk to you and ask you lots of questions.
Yeah.
You ready?
I'm ready. Excited to be here.
Okay, so I think I met you almost 3 years ago, but I'd heard about you prior. And I would love, I don't think I've ever heard this from you, but I'd love to learn about you for this show, first of all, so that our viewers can hear a little bit about you, who you are, but also I'm personally curious about what brought you to this health equity and health equity circle work.
Sure. So I guess to put it as briefly as possible, so I had just moved to New York on September 11th, 2001, and watched the World Trade Center fall from my dorm room window. I was actually in New York as a documentary filmmaker, but going around with a camera and documenting the event, September 11th, felt somehow kind of voyeuristic to me, which is a terrible instinct for a documentary filmmaker. But I did feel, the need to try to do something tangible and useful. And so I went to the hospital to try to give blood. That's what they were asking people to do. And so that, from that point on, I was very involved with anti-war organizing, several other different sort of social justice movements, and became a street medic, and slowly kind of realized that my passion was in medicine and healthcare, and around medicine and healthcare as a tool for social justice and health equity. So when I applied to medical school, I was actually a little bit hesitant about medical school, because so much of, in my view, medicine was, and medical school was divorced from, or didn't take into account the context of social determinants in health and all those things. Mm-hmm. So when I applied to medical school, I also applied to public health school, and basically got into medical school, didn't get into public health school, and then had to think about, how do you make the practice of medicine a practice of social justice and health equity? And so that was more about, those things were clear to me, and it was really about, how am I going to make my training to be the type of doctor that I want to be, inclusive of those things, so that you don't come out 4 years later plus 4 years of residency, having not thought about or engaged in social issues that whole time.
I'd never heard that story. That's a very cool story. So you were a lot smart. I went to nursing school, and you're a lot smarter than I am, obviously, because when I went to nursing school, I thought healthcare could actually fix social ills. And it seems like you went into medical school knowing that the structural issues that created poor health and well-being couldn't necessarily be repaired through medical care exclusively, which I didn't know.
Yeah, I mean, I think so. When was this? Back in 2004, I believe, 2005. I was a street medic at the FTAA protest in Miami. And similar to what you see right now on the news, the police overreacted and started shooting people with tear gas and pepper spray and pepper balls and all that sort of stuff. And so after getting a guy out of that situation and to the hospital because he had been shot in the head by a beanbag, I was walking back to the clinic, the makeshift clinic that we had, and you could just see all of the homeless patients, all the homeless people in Miami that had been kind of pushed out of the way for this Free Trade Area of the Americas FTAA event and for the protest that came with it. And so it was real clear that while we were there to provide healthcare for this event, all of these underlying problems were still there. And there was nothing that we were going to solve with Band-Aids and our medical kits, you know, the deeper problems that were the reason why people were sick and living poor lives.
That sounds a little too familiar, really, doesn't it? And I think about our history in federally qualified health centers, a 60-year history of starting with this desire to remove racism and poverty first and foremost, and allow people to have good, high-quality lives. And here we are 60 years later. You work in FQHC. I work in a federally qualified health center. You work in a federally qualified health center. When you think of, given that experience, your history, and your present work, when you think of those of us, I've had a lot of questions since the murder of George Floyd occurred, and a lot of sadness and anger here. And what do we do? What's the best response healthcare or primary medical care can offer to improve the world in which we live?
Well, you mentioned the 60-year history of community health centers, and I think, I guess ultimately what this is a question about is the same things that we're grappling with right now, the same questions of what should medicine's role be, or the health clinic's role be, or community health centers, how should they address these problems, are the same questions people have always had. And so it really is a question of what legacy do you want to continue? What history do you want to move forward? And so in the same light that there were segregated medical societies in the 50s and 60s in the South, and doctors vehemently supporting those things, there was also Jack Geiger creating the community health centers very explicitly as a effort not just to provide healthcare, but to use healthcare as an entry point into addressing all of the social order issues, all of the social determinants that affect people's health. And at the time, they called it breaking the poverty cycle, but we would now call that social determinants of health, social determinants of equity. So if you think about it that way, if you think about, there's always been this contest over the role of healthcare. And so then it becomes a question of, so what legacy are you trying to advance? And so I would say that what this moment makes very clear is how much those problems are still with us and how pressing they are. And so then it's up to us as individuals to think about our role, and then to move that on to our institutions as healthcare providers and healthcare workers, and then to think about how those institutions work with the larger community to move things forward. So that's kind of the arc. The way I would think about it is, so what should we do? Well, as individuals, we have to decide whether we care to address the injustice that we see, the inequity that we see. It's very possible for people who are not directly affected to say that's not my issue. impact me. And that same thing is true for an individual speaking about racism. It's true for a doctor who just takes care of the people who get to them, without concern about who gets insurance and who doesn't get insurance, that sort of thing. And it's very true for a clinic to be able to say, we're concerned about someone's diabetes and homelessness. They can go to the health department or they can talk to social service organizations around that. But that's not what we do here. We take care of healthcare. And because all these issues are interconnected, I would say that we have a responsibility at all those levels to address them, especially with the clout and power that healthcare and healthcare professionals have. And if we don't do those things, then we reinforce the existing and historical inequalities and inequities that we see.
That's good. I mean, when I think about our work here, and really the work in primary care, but I would say more exclusively the work in federally qualified health centers, what we're doing, I think you're very involved and have been in a leadership role in this. We're creating engagement with human-to-human engagement that ideally really flattens the power structure in healthcare, but it's imperfect. And then we ask people about their social and economic aspects of their life. We don't typically ask about racial discrimination, I will say. We haven't used that here. And then we look at quality and how we're doing through a lens to see how well we're doing with different racial or ethnic groups, different groups like homeless folks or veterans. And then I say often with physicians and people like myself, and then you need to speak out about what we're seeing and what we're watching. And I don't feel like that's enough anymore. I mean, that feels really inadequate. And I'm curious what your thoughts are on that.
I think that it's important to recognize that the pressure that we may feel as individuals to act in this moment is the point of, or is the value of all of these protests and demonstrations and outrage. It is putting pressure to act on us as individuals, on policymakers, on our institutions. And so that tension, I think that pressure is a good thing. It's a generative energy. Mm-hmm. And so then the question becomes, given my limited time, my limited energy, my limited capacity, how can I embody that effort here in my world? And so mm-hmm. if that's the health center, it's making sure is not perpetuating disparities in the healthcare that it provides, and then right. also in that it is somehow connecting to those larger questions. So, for instance, if you wanted to talk about the Black Lives Matter and the protests around police brutality, mm-hmm. so the healthcare center can make sure that its staff understand this issue and its impact on health, because the evidence is super clear how racism harms the lives and shortens the lives of Black people in America. That evidence is not in dispute. And so then there's an educational component for the people who work at the institution. There's also a standing up around those issues. So if one of the things we know is that police brutality and incarceration affect the patients and the community that are coming to the health center, then the health center needs to find a mechanism by which to voice its opposition to those things. And currently, that's a difficult thing for health centers to do because they're oriented around service provision. But I think it's possible for health centers and other social service organizations and service organizations to be part of and use their institutional power to be part of the community conversation around addressing larger inequities. And so, it's one thing for protesters to call for defunding the police or making police violence a public health emergency. It's a fully adding in a very beneficial way for a health center to say it's looked at the evidence, and this is not a question of politics, but just a question of good medicine, that yes, this is a problem. And as a population, as an organization sworn to improve health, we push for the public health emergency statement, for the orientation of funds towards social services instead of incarceration, all those things. And it may not have the immediacy of a protest or demonstration, but ultimately all of that pressure that's generated from protests and demonstrations dissipates if it doesn't get institutionalized. And so it's the people who are leaders in institutions like health centers that can make sure that harnessing happens, right? That transfer of that energy continues, and not just sort of in a we'll take it from here type of way, but that there is a collaboration with what's going on, so that when possible, the health center is adapting how it provides services to make sure that it's inclusive to everyone. So the IHI, the Institute for Healthcare Improvement, at one point they did a survey within their institution, and they de-aggregated the data by race. And so what they found was that the white people who worked there thought that IHI was a much better place to work than the Black people who worked there. And so that tells you that there's some work to be done at this institution. And it's, kind of on them whether they want to do that work or not. But so there are ways to actually know, are we addressing this problem well internally, and then externally, are we connecting with the issues that are coming up? Are we using our institutional clout and power to advance those things? And I know PHC is really trying to do that, along with several other organizations in Missoula, through the clinic organizing and the broad-based organizing, sort of making sure that those organizations that have traditionally been about service, providing care to individuals, are also part of the conversation about the whole, and what is a healthy society, what is a healthy community look like.
Yeah, no, and I would like to talk about the community organizing just a little bit, but you gave me about 5 other questions that weren't on my list. And so one is I wrote, so 2 questions. One is the internal response, and I want to think with you about that. The other is I sent you a note recently inviting you to a gathering that I have yet to put together, but with all the large healthcare groups in, and I assume you're doing something similar in Spokane, perhaps. Like when you say, obviously protests, if we don't rise to the occasion and have sort of an action-oriented response in healthcare, we have dropped the ball. It's the silence is violence piece. And I'm curious, when hopefully you'll be at the table, but when we're at the table with the hospitals and the other healthcare providers in Missoula, and as well as a funder for who's great, but I'm not sure we need funding. I'm just curious what you hope would come out of that kind of conversation.
Well, I mean, I think it's really the development of the capacity to be part of those conversations within a health system, and the health system has to decide that's a worthy goal. But then you also have to develop the ability to do that. So, in the hospital, we decided that it was a worthy goal to replace somebody's bad heart, and so millions upon millions of dollars were spent. Specialized staff were hired to run the equipment, to be able to crack someone's chest open, take down the lung, cross-clamp the aorta, bypass the circulation, open the heart itself, replace valves, put it all back together. Like, all of that thing is an incredibly complicated organizational effort and resource-heavy effort, but we determined that was worth doing. And so healthcare organizations could similarly say, addressing institutionalized racism or eliminating homelessness is a health goal worth doing. And we need to figure out some mechanism by which we engage in that conversation. So it's two things, I think. One, it's that commitment to do that work. And then secondly, it's the humility not to have to be in charge of it. So I see this all the time in my family physician, that family physicians who care a lot about issues, their default, and I think it's part of how we're trained, or the people who are attracted to medicine, is like, now I have to take care of this too. And I don't think that's right. I think the system has to have a mechanism to do that. And so if the hospital system has has some staff people, some organizers who are working with different community organizations to create, what is our plan for addressing homelessness, and what's our part as healthcare providers, and what's our part as an institution that's trying to push for policy change, then we can move those things. But it's those two things. It's, committing to address the issue and then acknowledging that we're only partial partners here. So, health is larger than healthcare, but healthcare is an important piece, and the healthcare sector is the biggest sector in the largest economy in the world. So if, like you said, it says silence is violence, if we aren't involved, then we are tacitly accepting the status quo.
Yeah, I love that. I think about this with health centers all the time. We were started with this understanding that the drivers of health and well-being, while healthcare has a critical role, it can't fix it. And yet we've been paid for healthcare forever. We've been paid for visits. And so therefore we think our job is to crank visits, which only marginally improves health outcomes, right? And we also are taught, we all go into healthcare. I think maybe you're different. You are different, and in the most beautiful way. I think we go into healthcare thinking we can fix it. And this idea of even benign power over, if it ever is benign, that might be an oxymoron, versus power with. So I'm curious if you could say more about that, about what does it look like if you could design what happens for Missoula next, and I doubt you're thinking about us that much. What could happen out of, what would it look like out of coming together and thinking the role of healthcare to both help support and partner with, and then stay out of the way as much as is needed? How do you picture that happening?
Well, I think there's a lot there.
Or is that what should happen? I guess I should say. Is that even the right question?
Well, so what should happen is that, like I said, with the humility. So let me put it this way. So I remember being in medical school, and we were in our neurology class. And at one point, one of my classmates turned to me and was like, I know this sounds stupid, but you know how people tell you only use 10%? Like, that's not true, is it? And basically that's just like recognizing a sort of widely held but evidence-free belief, and then being confronted with the reality of it and realizing that that was foolish and moving on, right? And so I think we have to do that in healthcare as well. And so the reality we have to acknowledge is that health lies primarily in the social determinants, and the social determinants are politically derived.
Right.
And so what that means is the same thing that Rudolf Virchow said, 150 years ago, I think, which was basically that politics is nothing but medicine writ large, and that physicians are a natural advocate for the poor, which is to say that the decisions we make about who counts, who gets resources, what's worthy of treating, are all political decisions that have a health impact. So, so as healthcare institutions, every society that has ever existed has had people who do healthcare, right? Like, that's part of the human condition, whether it is acupuncture or shamanism or cardiothoracic surgery. Every culture has some way to tend to the ills of the body, and so that is a necessary thing. But that doesn't fully explain health, right? That treats disease, but it doesn't necessarily treat health. So as healthcare organizations, we can be confident and proud and happy about the work that we do, improving people's lives, improving their health, etc. And we can also acknowledge that we are one part of a larger conversation around healthcare. So what would be amazing to see is that those social service organizations like the clinics and the food banks and the unions and the churches are coming together to educate themselves and to determine what it is that is needed to improve health in this community. And then then you figure out, well, who's handling what part of this and how does that happen? But that it starts from a different perspective, which is, it starts from an orientation around health equity instead of an orientation around disease identification and management or around, productivity for visits, etc. And I think there are, so I mean that's the conceptually what you want to see happen. And then who does that work? I think community organizing as a practice of building power and developing leadership is a great partner for learning how to do those things as health centers or as other social organizations. I think there's a lot of lessons to be adapted from that world into healthcare and social services for organizations that are willing to. And I think there's a lot of hope that can be done because it was already done, because it was done in the 60s. The original community health centers paired community organizing with healthcare. So in the health center, they provided medical care, they wrote prescriptions for food, and they also acknowledged that those things aren't sufficient for providing health. And so they had organizers working with them who created a sanitation program in the Mississippi Delta that created education programs for students and that created a food cooperative, helped fund a food cooperative so that people could be utilizing their skills as farmers to provide for themselves. And so in a similar vein, a health center could use its institutional power to help make those things happen without it having to be the health center that runs everything, or adding a new homelessness division to the health center. So if the health center started to see itself as part of a health equity consortium, then those partners can be working together on those different issues, and the health center can make sure that when someone has pneumonia or someone breaks their leg and they come to get treated, that they don't get discriminated against based on their race or their gender or their sexual identity, and that they get the best care that's imaginable, the best care possible. So we handle that part. We handle the giving good care to people who come in the door. It's just a question of making sure everyone gets that. And that's the quality improvement work for the health center. So that we are doing everything that is our task very well, but then also connecting out to other people when we see their other problems. So, just as a clinically focused example, we know from the evidence that that lifestyle changes can be more effective than prescribing metformin to stop diabetes. But it is much easier to prescribe metformin than to provide and support lifestyle change in diabetes. Well, the reason that's easier is not because of the laws of physics. It's easier because of how the metformin gets paid for, but the gym membership doesn't, or the peer educator doesn't get paid for, but the nutritionist or the pharmacy visit does. And so those are all questions, and those are all decisions around resource allocation that impact somebody's health, even though it's not in the right direction, right? It's not good evidence-based care. It's just the system that we have.
That's so interesting. I mean, I hadn't thought about it that way, and it makes it sound somewhat simple, which I know it's not, but I had thought that it's that a much, and it is deeper systemic issues of how legislation and politics relegate certain classes of people to situations where they really can't thrive. I think you're saying, yeah, that is true. However, within the context of healthcare, even we can do a much better job distributing resources in a way that helps people um, improve their health and well-being. That isn't just giving them medications. Is that correct?
Yeah, and the other piece of that is the reason why health centers and all other clinics work the way they do is, like you said, because they need to get reimbursed, and this is what gets reimbursed for.
Right, we get paid for it. Yeah.
So then one of our internal fights is to change those funding mechanisms so that we can do all of the things that improve someone's health, not just all of the things that you can write a prescription for.
Right.
And there is a lot of movement in that direction, a move away from fee for service and towards a more sort of global assessment and payment of healthcare, and that would make it easier to do things that are a little bit more group focused or population focused or community focused, as long as they have a health impact that's beneficial. And it's worth mentioning that the part of the reason why the original health centers were able to do all the amazing work for which they are recognized and held up is because they had a global budget. They had a block grant sort of approach to their budgeting. And so they could say providing food is health, right? Like putting a roof on this house is a health intervention. And we can't do that as much in our current day because in the Reagan era, health centers were sort of stripped of their social mission and oriented towards the healthcare safety net for the poor, which sort of tied them and wedded them to fee for service and so many visits before they can get there, all these restrictions around how you get your enhanced reimbursement so that you can keep the doors open to provide the services. And so that put some limiters on what a health center could do, even though health centers are still in many ways providing the best care available, especially for vulnerable populations. That put some limits on what they're able to do. And that was a political decision, right?
Yeah.
That was love for health centers from all political persuasion, but deciding to narrow the stuff you don't like. So I don't really like these justice programs, but I love that you're taking care of the poor and keeping them out of the hospital. So keep doing that, and we'll pay you for that part only. And so there again, it comes back to a political decision, which comes back to a question of power.
I really appreciate the fact that you are pushing. I mean, and I think about this all the time. Like, is it mission drift if healthcare is looking at housing and food? And for me, it's not at all. But I appreciate you bringing up our history and also how it's been beneficial in some ways to narrow our scope and benefits some of the people outside of those that we serve. I feel like I need another 2 hours with you. Or 4. I'm thinking of a couple other things I'm going to invite you to. I know you have lots of free time. That's a joke. But I have talked to you about some of these things a number of times, and you never seem like you get depressed or overwhelmed by the task at hand. And I'm curious how you are handling the present state of affairs. I mean, I was reading this Thomas Friedman op-ed piece that says pandemics leave nothing hidden, and this is before the protests started. And I'm just, how do you keep your energy and commitment when it sometimes feels sort of dark and impossible?
Well, I think that, well, first of all, let me just acknowledge the tremendous privilege that I have before, So I'm a physician, which means I have guaranteed employment as long as I want it at a 6-figure salary. I have like social respect, cultural clout, all of those things. And And so that makes it, you know, it's important to have that context in place, right? And and you know, while I have dealt with my share of racial issue, like racial animosity, I'm light skinned, so I have some privilege protecting me there. I'm heterosexual, you know, I'm a man. Like all of these privileges make it so that I'm not struggling as directly as some other people might. And so I think in that context, if it's a question of, you know, I don't particularly like the conversation around privilege, because I think it's more useful to think about a responsibility. And so, you know, as I said, I have this like, you know, very lovely existence, but that was socially constructed. You know, that was socially constructed because medical school costs more than the tuition I paid for it. Right? It was socially constructed because it's the taxpayers that pay for the healthcare system that pays me my salary, by and large, right? More than 50% of it comes from public coffers. And so all of that I have right now was an investment by the community, by, you know, whether people individually knew they were making that investment or not, it still remains true. And so in that light, this is just kind of making good. You know, all of the work for health equity and all that is just making good on an investment that was already made on my behalf. So that's one way to think about it. And then the other way to think about it is that, you know, I fundamentally think that that we have the capacity, that people have the capacity to make things better for each other, right? Like that's the whole value of community and civilization, is like the things that you can't get for yourself, you are better off with other people. And so we have that capacity, but it's not a given, right? Like I'm not a religious person, and I don't have this sort of like belief that the future always gets better. I think it's always a possibility. And so in that scenario, it's fully your responsibility to act and your opportunity to do so. And, you know, not everybody does, or people get lost, or they get depressed or overwhelmed. And I feel all those things too. But what it ultimately comes back to is, you know, we have that capacity to do better for ourselves, for each other, for our families and our children, and to be better. And so that's what it comes back to, right? So it's, you know, that's what it ultimately comes back to, is like, so what I tell myself, you know, is that things have been worse before and they will be better again. But you have to make them better.
Yeah. No, I love the idea of like pay it back versus pay it forward. We've had all this privilege that we didn't earn. And so it is just appropriate that we try and spread that and create that opportunity for others that has been given to us inappropriately, often, most of the time, I guess I would say. I think we have a little more time. I'm looking at the clock. So I have thoughts about community organizing, and I'm going to hold that for a second. I want to ask you, so Partnership Health Center serving 16,000 people. Of the 16,000 we serve, 1,000 are indigenous, or Native Americans from a number of tribes in mostly Montana. I think we have about 250 employees, and I think from a percentage perspective, we probably employ about 5%. We probably see about 5%, probably employ about 5%. That doesn't feel like it's good enough. And I'm curious how you see hiring and internal culture as a way to help reverse some of the disparities that occur in healthcare, and also attract people to services that I think are really great.
Well, yeah, I mean, I think, you know, you have to I think there's a recognition that people who feel comfortable with, who feel like this is for them, who feel like the culture of this place or its orientation is for them, will come forward to work there, to be involved, sort of at a baseline, right? So if you want other people to be more engaged and to feel like this is theirs, then you have to put some intention towards that, right? So by the fact that that the Odessa Brown Clinic was started by the Black Panthers, it has a certain culture and a certain value and mission that it carries forward in the Black community. And the same thing is true for a native-oriented health center, or for CMAR, as everyone has to speak Spanish that works, that is a patient contact area in CMAR. And so if you feel like we don't have enough engagement with the Native community, then I think the questions would be, what are the barriers? And I don't know the answers to that, but those tribes and their leaders within those communities can probably tell you whether they feel like PHC is their place or not, and why that is. And some of those things might be fairly easy to address, in terms of like, is there a way that students can get some exposure working at the health center, which helps them, ultimately become physicians or nurse practitioners or nutritionists or what have you, and then come back and work for the health center. Like, there are all sorts of ways that a creative organization can address those issues if it puts its creativity to that, right? So a lot of the times, there's a lot of creative thinking put to expanding access, to improving those kind of direct clinical care visits, but less actual effort put towards it. There's a lot more like, we think this matters, and the conversation is around deciding that it's important. But there's the having the courage of your convictions. There's the living up to that piece to be followed up on, and that's, I think, where that's the difference between all of the beautiful and flowery statements that are being made right now around Black Lives Matter. I mean, every organization is falling over themselves to let you know that they care about institutional racism, and that's a nice sentiment. But what is the reality behind that? So is Starbucks actually going to do something about addressing institutional racism, or they just won't want you to know that they feel your pain and that they also agree that because the one is of minimal use ultimately.
It takes that idea of silence is violence to inaction is violence. If you do nothing beyond make a statement, it's really not very meaningful.
Well, the thing is that we are not responsible for the world into which we are born, but we are absolutely responsible for the world that we continue to perpetuate and create. And so, it's a different thing suddenly, once you're done with school and into your career and continuing to do things, like it starts not to be the world that you have problems with. It starts to be the world that you are perpetuating. And so if we don't want to perpetuate it, then we have to put in work. And these things are difficult in that there's not an easy answer, and it will take time and resources and effort. But I think in healthcare, more than anywhere else, difficult is just not an excuse or an answer. I mean, brain surgery is difficult. difficult, right? Replacing the lens in somebody's eye is difficult. Like, we do those things every day, hundreds of times, thousands of times around the country. So we've decided to do difficult things already, and we know we have the capacity to do difficult things.
I like that. That's good. I like that. I think we're almost out of time, which is painful, but do you have anything that you think that we should read or resources we should tap into that you think will help really further both the understanding of where we are and also action in healthcare around where we are?
So I think there is, so there's a book called Out in the Rural, which talks about the original community health centers, which is a very good kind of history that kind of sheds some questions on the present. And that's, available wherever you get your books. I think there are lots of organizations that are grappling with these issues. There's a film series called Unnatural Causes, which came out in 2006, so it's a little dated, but it's basically a primer on social determinants of health and health equity, and is a great place to start. There are organizations like Public Health Awaken, the Praxis Project, trying to think about who else.
There's that Wilkinson. I think that Wilkinson started that, is behind the Unnatural Causes, Richard Wilkinson. So some of his books.
Oh, you're breaking up.
Oh, sorry. Maybe we're done. Can you hear me?
You just kind of broken up there. I couldn't really make it out.
I wonder if we're getting cut off. I want to thank you. This has been incredible.
Yeah, thank you.
And we will get you to Missoula to help us a little bit more think this stuff through. Looks like we're done.